Hello, everyone. Good morning, good afternoon, good evening. Today, we are very pleased to host this webinar with the OHBM Society on advanced tractography for personalized neuropsychiatric care. I'm Suchandrima Banerjee. I go by Suchi. I'm the Senior Global Director for NeuroMR. And today, I'll be joined by my colleagues, DJ Kwam and Jamin Chin, who will also be moderating the chat. We are also very pleased to be joined today by our guest speakers who have spent a remarkable, who have applied their research to advancing precision care for both psychiatric and neurological disorders. And I'll be introducing the speakers shortly. So everyone who has joined here today, we are all connected by our passion to study and understand better the human brain, which is the most complex system in this universe. And we want to understand it better, both in its healthy state and in different disease states. And since it is very close to the holidays, I couldn't help but indulge in a little bit of poetry. In the words of Emily Dickinson, the brain is wider than the sky, for put them side by side, the one the other will contain with ease, and you beside. The vision for our team is better brain health through AI-driven MR solutions and empowerment of neuroscience research. And this is structured around three pillars for increasing access through faster and more reliable exams that are more motion robust, that are more silent, that can be imaged around implants. The second pillar is to integrate imaging into the various phases of a care pathway from disease prevention, monitoring, and treatment planning. And then precision imaging. A lot of our research is dedicated towards establishing quantitative biomarkers for early detection and prediction and treatment response. So the topic of the webinar today really resonates with our vision and mission. So innovations make their way in the research community through conference proceedings and papers and patents, and then maybe through multi-site studies and so on. As a company, we have the opportunity to disseminate these things most widely. And we spend a lot of our attention and focus in integrating advanced techniques and putting them in the clinical workflow so that they can be leveraged by sites around the world and not just by the ones that have the technical expertise. And one example of this is our deep learning reconstruction technology, ARI-ConDL. So this is a technique that was introduced around 2020. It consists of an AI model that was trained to identify thermal noise and truncation artifacts in MR data and to provide a more intelligent reconstruction that improves SNR, improves scanning efficiency, and sharpness of the image. So this was propagated across clinical areas and imaging contrasts, as you see in this video on the side. And just in a couple of years, it has been really fulfilling to see how widely it has been adopted, with more than 2,800 global installations, more than 30 published journal articles with our academic and clinical partners, and more than 16 million patients scanned as of October of 2023. And this is what motivates our scientists every day to put their minds to work. This is showing, again, a snapshot for neuroimaging, specifically how ARI-ConDL has been propagated across contrasts and sequences for 2D, for 3D, not just for anatomical imaging, but for quantitative imaging, for tissue quantification, for diffusion, and has also shown very promising results for tractography. Let me give you a couple of more examples of how we want to bring advanced research techniques to the clinic. Most of you are familiar with a technique called top-up, which is used for distortion correction and diffusion. It applies a reverse polarity gradient acquisition to estimate the displacement map, which is then used to correct for the distortion. This has been used over the years in research groups around the world in research studies to correct for diffusion imaging. These exist in different imaging pipelines. But we wanted to bring this to the clinic on the MR console so that any site can use this for minimally distorted diffusion. It's called Progress, and here is an abstract showing how effective it is. On the left-hand side, this is a single-shot echoplanar diffusion imaging. On the left-hand side, you see the uncorrected image as an overlay on a 3D T1 showing quite a bit of shift, like 6 millimeters for cortical folds and 3 millimeter for the pons, which are very nicely corrected, as you see on the right-hand side with Progress. And here are just other views of this on 3D T1s with overlays on the 3D T1 image, again showing here in the zoomed inset for the ventricles how nicely the shift for the ventricles has been corrected with Progress. Another example is 3D Promo, is our prospective motion correction. It is navigator based. And what this does is while the scan is happening, it tracks the head motion and aligns the scan volume to the moving head. And this exists for most of our 3D sequences, and it not only reduces scan failures, but it improves segmentation of the brain subvolumes and their quantification. So to summarize, our approach to delivering precision care is to invest in the future, to advance clinical care and continue leadership in AI, and do all of this through collaboration. Because the value of an idea is in using of it, and chance favors the collective mind. To further boost our collective innovation, we introduced the G Connectome Working Group a couple of years ago, and the group has grown in leaps and bounds in just a matter of years. We meet periodically to exchange technology updates and best practices, but also for crowdsourcing of tools, pipelines, and ideas among collaborators, to develop new benchmarks for connectivity mapping, to find new applications for emerging techniques, and to foster multi-site studies and publications. So I hope I've been able to give you a little sense of our vision and what motivates us on a day-to-day basis. So now it is my honor and pleasure to introduce our guest speakers. The first presentation will be on personalized neuromodulation planning using white matter tracks, and this will be given by Dr. Helen Mayberg, world-renowned neurologist and founding director of Mount Sinai Health Systems, the Nash Family Center for Advanced Circuit Therapeutics, and Dr. Sueng Choi, associate professor in radiology and neurosurgery at Icahn School of Medicine at Mount Sinai. The second presentation will be on push-button advanced tractography for quantitative assessment of white matter tracks, and this will be given by Dr. Maxime Descoteaux, professor in computer science at the Shelbrooke University. So without further ado, I'll hand it over to you, Dr. Mayberg.
Well, it's wonderful to be with everyone here today, and thank you for OHBM for enabling Dr. Choi and I to be able to share the work from our Center on Personalized Neuromodulation and Planning for DBS surgery. A few disclosures of mine. I'll be talking about work on DBS for depression. The work has been licensed to Abbott. All of this work is now funded by the Brain Initiative, but past funding by several foundations. and I'll be talking in part about off-label uses of non-commercial devices. I first want to introduce our team at the Nash Family Center for Advanced Circuit Therapeutics at the Icahn School of Medicine in New York City. We have an integrative group of multidisciplinary scientists that work together on all aspects of invasive neuromodulation. And you'll be hearing about their individual work on and off, but I wanted you to meet them first in this slide. I want to first start with a general axiom about thinking about deep brain stimulation for neuropsychiatric disorders. I think the way we conceptualize these treatments now is that they are imaging informed because they are circuit-based treatments. We need to identify a location in the brain that isn't just one spot mediating a complex syndrome, but to actually see that these syndromes involve multiple regions organized in nodes, pathways, and circuits. And that pretty much, if one can conceptualize or have supportive evidence of this kind of organization, that is a potential target disorder where neuromodulation technologies, particularly invasive technologies, may be an appropriate step for treatment-resistant patients. The basics of deep brain stimulation is you have a wire, you have an electrode that actually is going to be connected to a implantable pulse generator, and through a very small opening in the skull, generally the size of a nickel quarter, one can actually implant with MRI guidance in stereotactic space this wire pretty much anywhere in the brain that you want. These implantations are generally done with a patient awake in an operating room with recording and actual clinical testing of the patient during the time of implantation, but they can also be done with the patient asleep without participation. And in that situation, the role of imaging is absolutely key. Once these wires are implanted, they're connected to the pulse generator, and depending on the system, one can just deliver the current that one wants to give to the patient, or one can also actually record what's going on from the site of the implant. Now, our experience, which I'll use as the prototype, began, more about 20 years ago. Again, in treatment-resistant depression, not generally thought of as a brain disorder per se, but over the last 30 years, it also, like Parkinson's disease or epilepsy, can be conceptualized and actually mapped as a circuit disorder. And through a series of experiments that preceded the DBS, a target in the brain was identified based on imaging technologies, basically PET scan technology. A target was selected using MRI guidance of just really quite gross anatomy combined with identifying this hotspot, which was a blood flow PET scan location, approximating it in standard space, identifying and confirming its location through an atlas, but again, through an individualized MRI. 2 electrodes were implanted on either side in and around the subcallosal cingulate gray matter to encompass with this wire both gray matter and white matter. And we used high frequency, turned the device on, left it on, and followed how patients did over the course of 6 months. And as we learned 20 years ago in the first 6 patients, if you implant in this region and apply high frequency stimulation in treatment-resistant depressed patients over the course of 6 months, 4 out of the 6 patients showed a robust antidepressant effect that was maintained following achieving that effect at about 2 months. What I want to point out in this first experiment so many years ago, that even modest stimulation applied every day in the hospital for about an hour resulted in really robust antidepressant effect that then when you turn the stimulator off, actually the effect was lost over the ensuing week and was regained again when we initiated stimulation. The other thing we were able to confirm at that time was that we could also get changes in PET scans and actually start to identify both local effects and remote effects. And it was really these early experiments, really with very underpowered experiments, that helped us to realize that when you stimulated in this approximate location, you got changes locally in everybody, but only if you also achieved remote effects into the medial frontal cortex, into the cingulate cortex, into deep parts of the subcortex, did you actually affect the sustained clinical change. And this was an important clue that we didn't yet appreciate. But what we did know clinically was that if you turned it on, left it on, we went from 6 patients to 20 patients, we got this similar effect. When we moved from Toronto to Emory, different surgeon, different psychiatrist, again, a similar trajectory of response in a similar cohort of patients, getting the mean effect by about 2 to 3 months. That was sustained here in this case out 2 years. And again, as we look at this technology, at this treatment in the most severe treatment-resistant patients, these are all patients who have failed at least 4 medications, psychotherapy, and also electroconvulsive therapy, ECT. If you get better, you stay better. And here, as you can see in the Emory cohort, now more than 10 years, that actually if you get better, you stay better. So the other thing that we learned over time, but we actually knew at the beginning, but did not have tools to actually map and plan our surgery, was that while we were targeting area 25 and knowing we were getting the white matter in and around it, this target is a network, not a region. And that millimeter precision is really essential to ensure that one gets into the network of interest. And when one thinks about that conceptually, again, for an imaging audience, this is obvious, but it wasn't obvious then. How do you actually capture the white matter that you know is going in and out of area 25 and is likely essential for the antidepressant response? So I want to make a point before I move on that there are other targets that one can use to treat depression. And there are actually 3 targets over the last 20 years that different teams with different hypotheses have been testing, and that each of them are white matter targets, not gray matter targets. And if one looks at the maps, the track maps in and out of each of these targets, one can see that they have some tracks in common, particularly these tracks that are reaching the frontal pole, but that otherwise these targets have very distinct and unique features. And just to point out that in the capsule and the medial forebrain bundle targets in green and blue, you get into lateral frontal cortices. These are not regions that are reached by the subcallosal cingulate target, which stays very much in the midline and uniquely impacts the cingulum bundle in its totality. So once one has a good sense of where, and one can reliably in individuals target this white matter set of bundles of interest, one can actually do a lot of other imaging guided but multimodal readout techniques that can help us to actually map what's happening, that can help us to refine and verify where we are in the brain. And I'll just share with you briefly, because the rest of this presentation will really focus on the targeting and the imaging methods. But I think it's informative to see how the focus of our group over many years on imaging has enabled a set of physiology experiments that really can get at mechanisms of why DBS in this region are evoking both acute, chronic, and sustained long-term antidepressant effects. So what Alison Waters has done with Sueng Choi is basically leveraged the fact that we have the precise target of interest. One can ping the brain with a stim evoked potential, giving not at therapeutic frequency, but 2 hertz frequency, and one can get a very characteristic physiology signal that moves through the brain with a very characteristic topology, moves quickly ipsilateral to the front of the brain, crosses the midline, then moves posteriorly over 70 to 100 milliseconds. And this is seen in every patient with every ping across patients and when patients are sick and well. And interestingly, looking at the contact that was decided to be the contact of interest, when you ping there, you get this reproducible effect. And if you move in this patient, 1 contact, 1.5 millimeters adjacent, you can get the same effect. But here in this second patient, move that same distance, you're impacting different white matter bundles and getting a very different electrophysiological signature. You can even see that there's a dose response. Low dose doesn't give a full early component, and that there's a dose response that is actually being evaluated to determine what should be starting dose for different patients. We can, again, use this technology in a different way. Knowing that we're in the right bundles in all patients, we can do experiments in the operating room where we can look at the first effect of bilateral stimulation, looking at what are the immediate effects of turning on what will be the stimulation parameters that will get patients well. And we can literally watch the change in the brain as it goes from sick to different, the release of this high negative mood and psychomotor immobility. And with machine learning, we can model the electrophysiological local field potential signal at the target site off the DBS electrode and look to see what happens between baseline and the end of 10 minutes of stimulation. Everybody shows a clinical effect measured a week later, and this 10-minute effect of stimulation results in a consistent decrease in activity in every patient with high degree of reliability, and that it is characterized by bilateral beta and unilateral right alpha increase. And this left beta signal is associated with the magnitude of the clinical improvement a week later. So we had our first image-guided electrophysiological marker of the acute behavioral effect. This set the stage of leveraging what is the availability of new technology where our pulse generator allows us to measure all the time what the local field potential signal is off the device, where we're implanting, where we're stimulating. And what that allows us to do, and what we've just published in a recent new series of patients, is we can look at the signal right in the first month when they're different but not well, and compare it with how patients are in the 6th month of stimulation when, as a group, they have all responded. And we can build a machine learning model comparing the early effects of STEM versus the late effects of STEM, and literally ask the question is there a physiological signal that can differentiate stable well from ill? And what we determined in the interesting work and important work from our colleagues at Georgia Tech, Shankar Alagappan and Chris Rizal, is that you can train a model, and with high degree of reliability, a robust model can actually differentiate this in all patients. One can then track when do you go from sick to well over time, just looking at the brain signal, and can actually see that there's a transition week where you have the early signal switch to the late signal, and you can give a rule and ask, when is that well signal stable? And then one can ask, as we did here in this graphic, the red is the brain state of stable electrophysiology stability, And how does that predict what the clinicians see, the severity rating scale, when that is 2 weeks stable with a predefined threshold? And one can see in this particular example, but here in the full model, that actually the brain readout can predict the clinical readout with high certainty. What we did learn, and this became important to go back to our imaging work, was to say patients get stable at different times. And the question is there anything we could have known at baseline that could have predicted who was going to get stable early versus who would get stable late? And what Dr. Choi and his team determined was that the white matter integrity in the bundles that we were stimulating, that the degree of white matter damage, as well as the connectivity within the cingulate between the target and the mid-cingulate region, actually was highly correlated with predicting the time to achieving stable wellness. In essence, the more damaged your brain, the more disconnected Area 25 from its connected network, the longer it took to get well. Not that you wouldn't get well, it just took more time. I want to close with the idea that imaging in our group has really been the foundation for both identifying targets, determining which patients to operate on, being able to plan a surgery with a predefined connectome template that is patient-specific. This platform has allowed us to take this method in a generalizable way to Parkinson's, to work in obsessive-compulsive disorder, as well as depression. It has allowed us, with new technology, to direct the current to particular predefined pathways so that we can impact and stimulate areas and study symptom and circuit selective behaviors. And it also sets a stage for being able to track the functional connectivity, white matter, PET scan, and physiology changes over time. So imaging has remained a workhorse of our team, and these methods developed with depression have been able to be generalized to other experiments. And I'll stop there and transition to my colleague, Dr. Choi, who will discuss the details of how we do this.
Thanks for inviting me for to present my work to the OHBM Society. So followed by Dr. Mayberg's presentation, I'm going to talk about more details about how we do the connectome-based targeting for depression DBS. So this is my disclosure. I'm consulting Abbott Lab, also I have a funding source from NIMH. So multimodal imaging in deep brain stimulation. So basically using multimodal imaging, we want to figure out where we stimulate and who have to stimulate and what should happen with this deep brain stimulation. We utilize like a diffusion tractography, functional MRI, bunch of different technique of the structural imaging to figure out, to answer this question. Today, I'm going to mainly focus on the where to stimulate, but I have just a couple of slides to show the who and what at the end. So conventional way to do the deep brain stimulation targeting is based on the anatomy. So some of the brain target location actually identifiable based on the anatomical landmark, like when you look at the STN or GPI. However, there is some target location for, especially for the psychiatric disorder, there is no clear anatomical landmark. For instance, of carousel cingulate for depression or anterior limb of internal capsule for the OCD. So right now, entire field of this deep brain stimulation targeting, especially in the psychiatric disorder, moving from anatomy-based targeting approach to the connectome-based targeting with advanced field of the brain connectomic. So this connectome-based targeting going to help us understand the mechanism of the DBS, also will provide personalized target location. So how we do the connectome-based targeting, basically is combination of the tractography and computational modeling. So based on the computational modeling, we can generate the we call volume of tissue activated that based on the given stimulation setting in that person. And then we look at their tractography pattern from the VTA to the whole brain. And as you see in the left side figure, depending on the location and amplitude, their tractography profile gonna look very different. So why we start to do the connectome-based depression SCC target selection? One of the reasons is the SCC, in the depression, SCC region is connected with a bunch of remote regions. In other words, mean is SCC DBS actually modulating of the activity within a network of regions structurally connected to the stimulated target location. Also, one of our patient, we do the first surgery and we turn it on the device. However, that patient never successfully get the benefit from the SCC DBS, and we revisit that patient electrode location and we adjusted it. So we do the second surgery, and then that electrode location was changed, and then patient suddenly get better quickly. She got the full benefit from this adjustment, and then we look at the connectivity profile and tractography profile from the first surgery, the previous one and new one, and we found that is a new one looks like a complete circuit. However, first one doesn't activate the entire circuit that's necessary for the therapeutic benefit. So small difference in stimulation location actually improve clinical efficacy in same patient. And so white matter activation pathway difference, as I explained here, probably can explain or improve the clinical efficacy of the entire procedure. So that's the reason we start to the connectome-based SCC targeting. So if we understand the therapeutic pathway for effective SCC DBS, we might improve clinical outcome using a patient-specific individual structure connectivity pattern with prospective surgical target selection. To do that, we need a 3-step. First step, we need to identify or define therapeutic pathway. Second step, using this defined therapeutic pathway, we have to identify the optimal patient-specific target location using connectome. And last step is we need to minimize translation error. Even if we predict the target location, somehow if we mistranslate to the stereotactical surgical space, it's going to cause because we are talking about millimeter resolution. So here is how we define the therapeutic pathway. We do the retrospective analysis of the 17 patients. We got their post-op CT image, and we localize the electrode, and we model the volume of tissue activated, and then we do the whole brain tractography to catch their tractography profile, and then we add up all of the responder together. And we call now that is a common white matter pathway, meaning is that because it's only responders common pathway, meaning is the therapeutic pathway for SCC DBS. Here is our result with that therapeutic pathway analysis. And we found that there is a unique set of the pathway is necessary for the therapeutic benefit. One of them is forceps minor, the other is the uncinate fasciculus, and last one is a cingulum bundle. Also, there is the fiber that is pronto to the stridor pathway. Originally we report this 4 pathway. Now we need a bit with more and more data. Now we are mainly focused on the 3 pathway. So second step, prospective connectome-based targeting. So now we identified our therapeutic pathway. So second step, we are applying that therapeutic pathway to the individual subject. We start with the deterministic tractography at that point, and we applied this technique to the 11th subject. As you see in the figure, left side figure is what we identified from the step 1, our therapeutic template. Right side is one of our subject. We identified that that's going to be that blue ball area is the sweet spot. And then we gave the coordinate of the blue ball to the neurosurgeon, and neurosurgeon decide the trajectory of the electrode and put the electrode at that location. So here is the comparison, anatomy-based and connectome-based targeting. First, we repeat the retrospective analysis of the 11 patients. We do the prospectively define the target location based on the connectome. And then we look at the common map. Again, the left figure, which I show you previous slides, and right figure is a new 11 subject result. It looks very similar, almost identical. However, clinical outcome is actually improved more than 31%. Anatomy-based targeting clinical outcome was 41%. With the connectome-based targeting cohort, we have a 72% response rate. So this responder, repeat that. So these responders show the same connectivity pattern as previously we reported as a forceps minor and unsynaptic fasciculus and cingulum bundle. So third step is how we can reliably translate our predicted target location to the near-time surgical planning. So we do the oral pre-processing before the surgery, and we also get the intraoperative frame, the MRI image, and we align that frame MRI image with the pre-calculated diffusion tractography, and we estimate the volume of tissue activated. And then with the frame, now we are in the exactly same space as a neurosurgeon, and then we predict our target location using software. So we developed the software called SteamVision, and this software allows us to do the stereotactic frame alignment and estimate VTA and visualize white matter tract, and also qualitatively matching white matter template to the individual patient, the tractography, and identify the electrode and contact based on the post-operative CT and MRI, and allow us to compare connectivity pattern among different settings. So with this SteamVision software, we also tested 10 new patients with the connectome-based targeting. Now our clinical outcome is 80%. 8 patients out of 10 patients getting better. Here is like how we evolved on the SCC-DBS from anatomy to the connectome-based targeting. As you see in the top left figure, cohort 1 is our anatomy-based targeting, and cohort 2 and 3 is the connectome-based targeting, and 3 is based on the software that we developed and real-time transition of our target location to the surgical space. We improved the clinical outcome from 41% to the 72% and 80%. On top of that, also patient getting better much quicker. Patient get the benefit as soon as we turn on. Instead of the anatomy-based targeting, if patient get better, but it take a much longer time. Here's I'm gonna show the couple of next steps what we are doing. Like now we are almost finishing up to develop the automated quantitative connectome-based targeting method. So how we do that is actually we extract all of the necessary pathway before the surgery, and then we overlap that 3 pathway region and define the sweet spot or the optimal location. Previous approach, connectome approach, manually we generate the seed and moving around the space and try to find the exactly same tractography profile. Here is we already extract the bundle and just visualize that bundle, and then we can easily identify the sweet spot location. So we tested in 10 patients, we have a still 80% response rate, and we are adding more patients for this automated quantitative connectome-based targeting method. This method only takes 5 to 10 minutes to identify the sweet spot. Previous method, I and the neurosurgeon and Dr. Mayberg, psychiatrist, everybody have to sit down together and we spend 30 minutes to identify target location. So this automated method is much quicker and much precise. And second thing, with the collaboration with the GE, we also testing deep learning reconstruction method in this connectome-based targeting. We tested a couple of subjects, and this deep learning method, MR reconstruction, AIR, ReconDL, give us a little bit better the tractographic precision. As you see in this figure, that with the conventional recon method, we having a hard time to catch the sharp turn of the unsynaptic fasciculus. However, Deacon DL method give us a much better, or much more sensitive to catch this sharp turn of the unseen fasciculus pathway. So here is my summary and conclusion for the where. Connectome-based deep brain stimulation targeting is a paradigm shift from the focal effect on stimulation toward to the brain circuit-based stimulation, combined with the modern-day neuroimaging technique, fMRI and tractography. Connectome-based DBS help us to better understand mechanism of DBS and predict patient-specific optimal target location. Especially this method is necessary for the psychiatric DBS because there is no identifiable anatomical landmark. Personalized neuromodulation planning using this tractography technique requires 3 steps. First, we need to define the therapeutic pathway that associated with the clinical improvement. And second, we need to personalize target selection using individual patient-specific tractography by maximizing connection to this therapeutic pathway. And lastly, we need some reliable translation of the predicted target to the surgical navigation system, such as STAIR system or BrainNav. Here is some of the just brief slides, what we are doing, research in progress for the WHO. Actually, we look at the baseline functional connectivity to figure out, our goal is that we want to know who's going to be best candidate for our SCC DBS surgery. We look at both functional connectivity, we also look at the white matter integrity. And we found that there is some relationship. For instance, the functional MRI, there is some relationship between our target location to the insula. If their functional connectivity is negative, it probably take a longer time to get better. Same thing, if there is some white matter damage is already happened in the cingulum bundle, that patient take a much longer time to get better. So now we are utilizing this advanced neuroimaging technique for the patient selection in SCC DBS. Second thing is we want to understand what happened with our stimulation. So now we are looking at the functional and structural change with the chronic stimulation. We already published one paper recently about the PET change with the chronic SCC DBS stimulation. And we found that salience and default mode network is associated with our clinic. The salience and DMM change is associated with our clinical improvement. We repeat that, although it's a couple of patients, we found that using the functional MRI, we found the exactly same pattern. Default mode network and salience network change is actually associated with their clinical improvement. On top of that, also white matter change. As you see on the right side, white matter at the beginning actually somehow repairing over time with the chronic stimulation is also associated with the clinical outcome. So here is my lab member, and thank you for your attention.
Thank you, Dr. Choi. It's amazing to see how advanced tractography can really make a difference in precision treatment planning. So now I will hand it over to Dr. Descoteaux for the second presentation.
Hi, everyone. I'm Max Descoteaux. Thanks for the invitation. It's a pleasure to speak to you today on the press button advanced tractography for quantitative assessment of white matter tracts. Before I start, let me just disclose my conflict of interest. I'm a co-founder and shareholder at iMecha Solutions. So press button, what? So are you telling me that we now have quantitative tractography is press button? What do I mean by that? Can we truly press a button now and get a full brain tractography results or a tractogram automatically? Are we there yet? And from there, can we get quantitative white matter tract assessment that is segment in different white matter tracts or white matter bundles and start quantifying their microstructure or their integrity? Well, today's talk is about this topic, and I'm going to show you where we're at as a community, where we're at in terms of commercial products for the industry, and you will see that we have progressed quite a bit as a community, but of course there's still some open challenges and opportunities for improvements. So if you haven't read this paper in the past, this is a definite must-read paper where people might be surprised in the crowd that I'm claiming that we can have press button tractography today, because one of the conclusions from this paper was that it's easy for tractography to get lost. Tractography is a ill-posed inverse problem, and tractography validation is still a very much open question. So a lot of people have focused on the challenges and the difficulties that came out from this paper. But let's not forget that there were very positive feedback from this paper that says that tractography does work well on most of the large white matter fiber pathways. So we can reconstruct most of the true positives using tractography. And not only that, that current pre-processing pipelines for diffusion weighted imaging and diffusion MRI in general, correcting all the different artifacts, do improve tractography. And this was shown quantitatively that, for instance, correcting for eddy, for motion, for distortions, denoising images have an impact on improving tractography and hence connectivity. And so this goes in line with a recent survey from the ISMRM diffusion study group, which was held now, almost 5 years ago, where we have efforts now going on, which will produce more or less 4 papers in the coming year on best practices and consensuses that were obtained in DTI, beyond DTI approaches, clinical tractography, and diffusion preprocessing. So I just wanted to point this out that over the last 20 years or so, we've done a pretty good job as a community to come up with automatic software pipelines and solutions that make clinical tractography and diffusion weighted preprocessing much better than it used to be. And so I don't want to promote today any specific tools, but what comes out of these metadata analysis and data-driven approaches is that there are several very high-quality pipelines out there in the community, powered by most of the international community developing software around diffusion MRI. And if you put these bricks and pipelines together, recently, TractoFlow is one pipeline. QSI Prep have started showing very promising, reliable, reproducible, and robust results to create tractography, connectivity, but also quantitative tractometry. And so, as of today, starting from a diffusion-weighted image or MRI protocol, accompanied by a T1 weighted image or not, well, believe it or not, we can press a button and obtain a full brain reconstruction tractography results, which I call here a tractogram, which is millions of streamlines virtually reconstructing the white matter pathways of the brain with different levels of quality, of course, but this along with the diffusion MRI preprocessing pipeline is automatic for most part. One key challenge is that we were able as a community to solve in the last 15, 20 years is the crossing fiber problem. As we all know, crossing fibers occur everywhere in about 2/3 to 90% of the time between large fiber populations. And so it's important when you choose a diffusion MRI processing pipeline to choose a local reconstruction method that handles crossing fibers. For instance, spherical deconvolution, but there are other methods that use multi-tensor reconstruction or other models to basically locally at every voxel reconstruct the multiple fiber pathways going through each voxel. And this occurs in a big proportion. It's occurrent between 2/3 and 90% of the time. And if you do choose an algorithm that supports these crossing fibers, well, we've shown as a community that we can reconstruct more of the true positives. So that was one of the conclusions in this Nature Communication paper, that one of the challenges is to reconstruct more of the fanning and the bending of existing tracks, while controlling for false positive connections. And so if you choose an advanced pipeline handling crossing fibers, as you can see here in the left, you can get much fuller reconstruction of existing anatomy, more fanning, more bending. You can reach cortex better, fanning under the cortical blades. And so this is a much improved tractography over classical DTI tractography that was invented in the late 90s and most of the beginning of the year 2000s. And so this sort of pipeline is nowadays even available. This is an example from the Brainwave software that GE HealthCare has. And so it's possible to integrate these advanced crossing fiber robust tractography pipelines now directly at the console, where from a diffusion MRI protocol, you can get this, not only the DTI reconstruction, but also the advanced tractography handling crossing fibers. So this is a nice improvement, which we've seen now make its way towards the industry. Then what's next? From a whole brain tractography, what do we do with this tractogram? Well, we can press a button nowadays and extract major large fiber pathways. Here I'm just illustrating a few from a few association tracts, a few parts of the corpus callosum, the inferior frontal occipital fasciculus, the uncinate, the ILF, and these tracts now are automatically extracted by segmentation algorithms that basically segment together tracts that share known pathways of anatomy and known features such as shape, length, and different cortical termination. We can go further down the pipeline and then divide these tracts in different sections. Here you see an illustration where we've divided the tracts in 5 sections from head to tail of each white matter tracts. And so we can start quantifying what happens underneath these tracts with our different diffusion MRI measurements. But such approaches is also now available in commercial products. For example, here, this has recently been integrated in the Medtronic platform in the neurosurgical planning, where you can appreciate probabilistic whole brain tractography using robust crossing fiber ODFs, where different tracts have been segmented in different white matter tracts, such as the arcuate fasciculus, the optic radiation, the frontal aslantelat, even in the presence of a large tumor. So again, this is a nice progression of our research-based tools, of our advanced pipelines towards clinical application and in the industry for neurosurgeons. What can we do next? From all these white matter pathways, now we want to quantify what's going on with the microstructure, hence the word tractometry. So here, if we zoom into the fornix, the right fornix, we can start extracting classical DTI measures, apparent diffusion coefficient, the fractional anisotropy, the axial radial mean diffusivity, the volume of the tract, and position a patient here in the dot with respect to a normative reference from 20 to 80 years old. So this is, of course, work in progress. There's lots of caveats here on how to pool different data together, different acquisition protocol. But this is thanks to large databases, large efforts in harmonization. This is starting to be possible, and to actually follow a patient in time. As you can see here, it's 5 different time points from the same patient that we can now map on a reference. And now I've zoomed into the 35 to 45-year-old range, and you can appreciate how the DTI measures and the volume of the fornix is stable or changing over time. And so this is starting to be possible, and again, available in an FDA-approved product where we have 30 or so large white matter fiber tracts, a normative reference, a summary of how the white matter quantitatively compares to a normative reference, and where you can actually follow in time, longitudinally, the evolution of a patient or of a healthy control. So again, a very nice progression from research developed tools in the research world, in the open domain, that are now slowly making their progress to clinical products and FDA-approved solutions. But solution is not solved. All the problems haven't solved yet. So I want to keep the word out that there are still challenges that need to be addressed. One of them is tractography has severe limitation under the cortex, near the deep structures around the nuclei, the brainstem, and in the cerebellum area. So it's not all solved problems. And so one has to keep in mind that if you're interested about white matter anatomy around these parts of the brain, well, it's harder for tractography to track them reliably, and they're underrepresented in the whole brain tractogram. So this is kind of the position challenge where we need higher resolution, probably more information from the T1 weighted image to boost and advance our tractography algorithms. Another challenge is the pathology challenge, where what happens with pathology. Here I'm just indicating a normal aging brain towards an Alzheimer's disease brain, where we have brain atrophy, less white matter, more CSF, less cortex. And so this will typically lead to different challenges in the tractography pipeline. The different way we mask, we tune our parameters have to be adapted for these brains, because we have to realize that most tractography algorithms have been developed for healthy young adult brains in the research community. But if you're careful and if you adjust your parameters, you're careful about your white matter mass, you deal with CSF and the ventricle swelling. I'm just showing you here examples of a very hard to track white matter fascicle, which is the fornix, that we can reliably reconstruct in the ANNI database for normal controls, for mild cognitive impairment in the middle row, and Alzheimer's disease on the bottom row. And you can appreciate the fornix shape and density changing across ages, and that it is possible to track it and to quantify it with current technology. Last but not least is white matter lesions. So with different pathology, whether it's MS or other, we have white matter lesions, which are a nightmare for tractography because they create holes in our masks. And so that has something that has to be taken into consideration, especially if you're using tractography in clinical applications. And I said last but not least, but here's the last thing I want to mention is about specificity. Everything I've been showing here about quantitative tractography has been reproducing or reporting DTI measures under the tracks. The diffusion MRI community has been actively developing local reconstruction model that can actually disentangle different contribution of the signal for different fiber population and start assessing the integrity or assessing the white matter in different pixel, that is in different fiber element. And each fiber element should have its own little microstructure environment of myelin content, axon content, intracellular water content, and extracellular water content. And so this is still a very active field of research where these methods still need to be transitioned toward clinical products and FDA-approved products. So in conclusion, I think there's lots of hope to use what I've shown you today to start predicting, monitoring, and diagnosing white matter healthiness in clinical population. And here I'm just borrowing some images from latest normative modeling papers in the brain, in a special brain issue. But the hope is that each white matter fiber tracks can have its different profile under different white matter assessment. And you can determine if a patient is outside the norm, and if this patient can come back inside the norm or deviates from the norm as time goes by. So in conclusion, I hope I've convinced you there's lots of good tractography pipelines out there, that you should use them, and there are quantitative white matter pipelines as well. We're starting to have commercial solutions available directly at the MRI console for neurosurgical application, and some for tractometry. and more large application of white matter assessment. There are some reimbursement code that will be coming up soon that hopefully will help doctors prescribe these numerical exams and be reimbursed by them by insurance companies. But there are still lots of challenges and limitations of opportunities for future PhD students that want to help improve the technology, better handle crossing fibers, bottlenecks, fanning fibers, different parts of the anatomy, pathology, and handle false positives better. So with that, I'd be happy to answer some questions later, and I thank you for your attention.